got an action-packed hour ahead of us, and so normally I give people 5 minutes to commute in, but today is our first international speaker for 2026, and so I want to give her bio due consideration and talk a little bit about Dr. Jenny Rudolph. So she's a leadership and learning expert who helps healthcare teams master high-stakes conversations, saying what matters most with candor, clarity, and care. Jenny developed the with good judgment approach to feedback and debriefing, which blends high standards with high regard to strengthen both performance and relationships. A lifelong athlete, Jenny brings the discipline and delight of mastery learning to team development and culture change. Her early research on learning under pressure in nuclear power and chemical plants now informs her work in hospitals, where psychological safety and learning culture are mission critical. She is the Senior Director of Innovation at the Center for Medical Simulation in Boston and a lecturer in anesthesia at Harvard Medical School. Jenny holds a PhD in organizational behavior from Boston College, studied system dynamics at MIT, and is a fellow of the Society for Simulation in Healthcare. On a more personal level, she was a member of the U.S. World Champion Women's Lightweight Rowing Team and played varsity basketball at Harvard College. It was such a joy to connect with Jenny to invite her here today at our University of Toronto Temerity Faculty of Medicine SimCity rounds. And I'll tell you personally, I have been emailing her for over a year, and I was like, why am I not hearing back? And it turned out my email got lost. And when we did connect, it was so heartwarming to see how receptive and eager Jenny was to share her knowledge and wisdom as it pertains not just to simulation, but I think that this topic we're going to cover today can help all of us in many other domains of our lives. And so without further ado, Jenny, it's all yours.
Thank you, Petal. So happy to see you all here, and I know some of you, and I'm hoping to get to know some of you a little better as we go. And as I start, I wanted to recap or restate what my main topic is going to be today, but I'm going to diverge from that in a moment and talk with you all a little more broadly about the role of simulation in solving problems for our colleagues. And I'm going to be kind of interested in your take on this. So my topic today is from conflict to collaboration, how we can create high trust duos at point of care. And I got interested in this because a CMO from our system contacted me about 2 years ago and said, we're having a really big challenge between residents and nurses at point of care, and we are struggling with having positive conversations at this sort of interprofessional interface. And why this was a problem was a couple reasons. One, residents were, as you may know, asked to give surveys to our accrediting agencies and so on, and we're not surveying their learning environment very well. They really had problems with what was going on for them as they felt supported or not supported as they tried to care for patients. The other issue, though, was it was really demoralizing both for the residents and for the nurses. And at this time, which you all are very aware of, staffing issues are really challenging. We have so many new nurses. And so both for our nurses and for our doctors, this was a tough issue. But I see this primarily as just one example of the many things that we need to work on as simulationists. So I want to just talk about a kind of problems that people face, and then I'd love to hear from you guys what might be happening within your systems. So when the simulation era, modern simulation era, started in the early 90s, we sort of had, if we build it, they will come kind of approach to simulation. And it was mostly started in anesthesia, and we built wonderful complex simulations for people to mostly manage crises. And as we've evolved, and especially in the last 10 years with the work of Victoria Brazel, Chris Rusin, and others, we're thinking more and more about what are the translational goals of simulation? What are the serious problems in our healthcare systems that we can help solve with simulation? And I think this has become even more urgent post-pandemic as staffing levels are lower, cost pressures are higher, and we really have to justify our existence to some degree. So I wanted to just give a few examples of how people are justifying their existence. And then, as I said, come to you and just think about with you, what are the problems you're seeing? So I think what I'm doing right now is sort of framing the example I'm going to talk about with, which is these dialogues at point of care. But I wanted to start with what are the really tough problems for different healthcare systems? This happened to be one for my healthcare system, but you all might have others. So, for example, New York City had a lot of things it could focus on with simulation, but it has noticed and really been working on the disparities between maternal care for white women and versus women of color. And so, for example, across the New York Health and Hospital system, they made a huge commitment to improving maternal management of postpartum hemorrhage and other crucial things. We're working with a group in Montana, Montana State School of Nursing, and one of the big issues there is rural generalist nurses who can manage anything from delivering a baby to suturing a laceration to standard, sort of much more internal medicine type challenges. And so when we address what the state needs or the city needs or our system needs, my impression is that our partners are much more willing to give us resources or sustain our programs. So we've started talking about ourselves as partners first and designers second, which I think is really hard for us as educationalists because we like to design wonderful sims. Your city mate, Andrew Petrosaniak and Chris Hicks, have done some wonderful work on design thinking inspired simulation, which is the same type of approach. So I'd love to hear what kinds of problems are you guys currently working on solving with sim, or do you hear about and you wish you could solve with sim?
I can go.
Yes, Sev.
So, thank you. Well, I can share my experience as director of Sim Center in the sizable teaching hospital. The problem that's been bugging me for more than a decade is uh, inadequate maintenance and development of team working abilities in real clinical settings. So obviously, I'm not a pioneer in that, and more codes have been advocated for, and there's good evidence that they improve patient care at many different levels. So the success story is that we were able to have a robust emergency department mock code system where every month we have mock codes for the entire team. But where we are failing is to gain support from senior leadership in the hospital to have it hospital-wide.
Yeah,
And I failed myself in advocating enough or creating enough traction, whatever the word you choose to put to that. But from my perspective, it's very easy to work with people as a partners if they have interest and understand what the problem is. And it's much more difficult to work with group of leaders who are understandably pulled apart by different problems and priorities, where somehow uh, true patient-centered, patient safety culture is not part of the strategic development, even though it may be on the paper. Because
yeah,
without simulation, it's impossible to really develop, maintain, support clinical teams.
yeah. Sev, I resonate with that pain point very much. And part of my thinking and message in this early part of the talk is I think we all struggle to find the pain points into which we can then pour, for example, teamwork. But that's not the way that people are, our partners often think about it. They think about, how do I reduce the number of catheter-related bloodstream infections? I need that to go down, so my length of stay will go down so that I can not have, wasted money on infections and not have my patients suffer from infections. And that's a way I can work on teamwork, even though they don't care about teamwork, they care about reducing infections. So I'm thinking more and more about, how do we take whatever problem people have and plant our possible solutions there.
Can I add just one little thing? The challenge with that is that it all, again, it's culture based, but it all based on the quality of reporting of near misses.
Yes.
So disaster situation do trigger some short-lived effort, but programmatic support and having this culture change in the institutional level, that's where the challenges are. We had quite success with developing a course and distributing it every month or 2 months for adult procedural sedation because they had a couple of near misses. And we had a good success story instituting training around catheterization of the central veins to fight the infection. But it's very episodic and doesn't translate into the systemic culture change.
Yes, I think that's really a struggle, Sev, and continuing to chase what are the current pain points is often difficult. Sarah Branton, I just saw you said you agreed. I don't know if you want to add anything.
No, I just couldn't agree more. We struggle with that here. We've embedded in situ mock codes for various different types of codes across the organization. It's the uptake and accountability and support to have that training time and that space, and for all team members to see the value and importance. I'm biased as a nurse. I've worked with Sev when I was in the Emerge at Sinai many years ago. But at the same time, getting physicians to the bedside when they're like, well, I can't bill for this, is some of the pain points that we do experience. And I'm at a smaller community center, but we do the best we can. But I can't agree with this advocacy more than what the two of you have just talked about.
Yeah. So let me pivot to the luxurious position I was in that case, which is a CMO asking that something be addressed. And so I'm going to just share this little success story, or maybe I shouldn't put the word little, this success story with you. And part of what I want to do here is suggest ways that our simulation mindsets and skills can be used to really make a difference at point of care. And the project I'm going to talk about was a relatively light intervention and seemed to have a pretty big impact. And so I'm going to do two things. I'm going to talk to you a little bit about the project, but I'm mostly going to focus on what we taught and give us all a chance to sort of have some batting practice and thinking around the issues of how do we translate conflict into collaboration at point of care. The simulation mindsets and values that we poured into this project are the idea of trying to have people reset themselves when they think their colleague is an idiot, basically, or when they're really frustrated. And how do you get curious enough to inquire what is their concern, what's going on with them, and how do you collaborate with them? And so one of the big things we did in our process of trying to be partners first and designers second is, in the 4 acute care units we were invited into, a labor and delivery unit, an emergency department, a neuroscience ICU, and a neurosurgery unit, we conducted multiple days of interviews and observing grand rounds. All this was done by my wonderful colleague, Laura Rock, who's a critical care physician, to learn what these teams were really struggling with. And what you're going to see me present today is really that journey of how did we, once we identified what their problems were, how did we use what we know from simulation to help them address it? So I'm now going to pivot into a little bit the problem statement that we got from the CMO. It was not only about the point of care interactions, but they were really concerned with the psychological strain and stress for each individual healthcare team. And what we did was we kind of reframed their problem, which they had described to us as mistreatment between residents and nurses. And we said, hey, you know, we're talking about mistreating each other is not going to be a really powerful entry point. So we tried to flip it to thinking about mutual support at point of care and how do we plant connection and learning into the units to better support people. And the way we did that was to focus on a very short point of care conversation of when there was a little bit of a disagreement about how to manage a patient clinically. So we first did this work about 7 years ago in a cardiac care unit, and we have published this paper in Chest, and I put a QR code up there for you in case you want more details. And Petal, I'm sure we can provide them the paper and so on if they like. And building on that work, we then tried to create a process where we can transform unit culture one conversation at a time. So I'm going to pivot now and sort of invite you to join me in what we did with them and try out some of the things we did with them. I'll be asking you to text into the chat or talk with me, and I know many of you are at lunch, so just do what you can. So if you would be willing to sort of reflect on your own practice with respect to what I'm going to talk about, love to hear your thoughts by voice or chat. And we'll end the session by inviting you to think about what is your reset routine internally when you're very frustrated or annoyed with a colleague that you're interacting with. Okay, so let me get started. I'm going to share a video of one of the exemplar conflicts that we generated based on our interviews. So what we did in each case is we conducted these interviews in the unit, and based on that unit, we created, instead of a simulation, we created a video of a very typical conflict. And we asked the teams then to work with us to reflect on that and practice developing some alternative skills. So if I could, I'm going to tell you about the patient and providers you're going to see, and then I'm going to invite you to watch this video and then think with me about it in terms of how do you manage conflict like this? How does this kind of conflict feel to you? So our patient is Bill Christo, and he has a spouse and 3 girls. He's 53. He has non-ischemic cardiomyopathy. He has severe end-stage congestive heart failure. He's not a transplant candidate. And the consultant or attending that you're going to see is ask the nurse to prepare the patient for a HD line or hemodialysis catheter. The nurse that you're going to see, Alyssa, has been spending time with Bill and his family, as much as 12 hours a day over the last week, and is very concerned about his state. And the nurse, Laura, who you're also going to see, is also very concerned, but has a very different perspective on what is the right thing to do here.
Oh, hey, Alyssa. I want to start setting up for the HD line so we can start CRRT.
Here we go again.
What was that?
Nothing. That's just really the plan for this patient.
Yeah, I mean, we have to take a lot of fluid off. Nephrology's on board. Yeah, that's the plan. We need to do it fast.
All right. I just feel like a goals of care meeting would be more beneficial. It's futile.
You know what? We promised we would do everything, and for now, we have this plan.
All right. Another poor patient. You guys aren't the ones in the room for 12 hours watching him suffer.
Raise your hand if you've ever been in a conversation like that. All right. Well, I don't exactly know. Maybe you have, maybe you haven't. But you can imagine both of these people are having thoughts of frustration about each other and may even be sort of thinking, WTF is that person doing? So let's talk a little bit about what is this conflict? And what are your reactions and thoughts about it? So just talk to me for a minute, text into the chat, or just come off mute. What do you think about when you see that conflict? Both parties seem to have different goals. There's not enough time in their day for collaboration. Yeah, interesting. Non-open communication, seeing both sides. They've made assumptions. Really interesting idea there. So yeah, I think, what does the patient want? Right. Was there a discussion? I think that's why Alyssa's wondering about the goals of care meeting. They don't seem to be very curious about each other. Right. So we're sort of, they seem to be flying blind, at least with respect to each other and with respect to the patient's wishes. So what is this conflict here? It sounds to me, and you guys are sort of noting this already, that the surface conflict is comfort care. On the one hand, it seems like Alyssa's pushing more toward that, and Laura's more interested, Dr. Laura's more interested in interventions. And we don't really know what they're each thinking, but let's say that we could find out, or they asked each other. The nurse, Alyssa, might be thinking something like, I want to make this patient comfortable, I want to help the family, and I want to avoid futile care. I think she's really worried about that. And Laura, Dr. Laura might have given the patient a promise to help him get better for some reason in the short term as much as she could, or give him more time for some kind of family event. And she also has a mental model that his currently bad exacerbation does not necessarily mean the end. So let's just talk about what's going on here from the perspective of negotiation and collaboration. In the negotiation world, we often think about what people say aloud, like this patient needs comfort care, this patient needs an intervention. We call it a person's position. And similarly, if I were negotiating for a car, I might say, I'll pay $500 for the car. But we have some kind of underlying interests often. And in this case, Laura's interests might have been, I want to give this patient more time. I promise the family something. Or Alyssa might have an interest of, I can't stand by and feel like I'm, giving this family false hope. That doesn't feel ethical to me. But unless they know those things about each other, it's really hard for them to come to some sort of agreement. And the challenge for us that we found in this project is nurses and residents just kept butting heads when they assumed, as one of you put in the chat, they knew what the other person was doing. And we sort of thought about this as a kind of certainty-driven culture at point of care. I know what's going on. I have the full picture. I don't have to be curious. And that kept reproducing impasses. The challenge is in social cognition, the studies of social cognition, which is what's at play when we're interfacing at point of care, is we tend to overestimate the situational factors that drive my decision making. My first person, I can't do what the doctor's asking me because of these good situational reasons, but I tend to think she's not doing the right thing because of bad character. So this pattern is wired into us, and I don't know about you, but I often have a feeling, indignation face like this when I'm driving, or when I think somebody is doing something for a bad reason. And I'm very aware of the situational factors that constrain me. And not only am I aware, but I am so sure I'm right that this is kind of turbocharged to make me feel indignant and angry, making me all the less likely to listen. So when we talked to the nurse and doctor, for example, on the labor and delivery unit, when a woman needed to emergently go for a C-section or something else, they each had completely different views often of what was going on and very little ability to quickly understand each other's perspectives to optimize care for that patient in the moment. So why did we focus on conversations for this particular project? Some more details here. In this project, one of the big problems was female nurses and female residents. So women residents were finding that nurses tended to challenge their orders and their decisions more than their male counterparts were being challenged. And our clients, our sponsors who asked us to do this work, really wanted us to try to tackle some of these gender-related issues. And I immediately sidestepped that and told them I was not going to be able to solve matters of structural sexism in our system or whatever else was going on, but I could work on creating a culture of mutual support at point of care. And the lever for that is conversations. And I want to tell you a little bit about why. So most of us tend to think of culture as sort of set or immutable, our unit culture, our organizational culture. But in fact, what we know from research in the field of organizational behavior, where I come from, is culture is dynamically created moment by moment. And one of the ways it's dynamically created is how we talk to each other. So, for example, many of you may be familiar with Amy Edmondson's work regarding psychological safety and speaking up. And she and Ingrid Nembard have a really famous paper called Making It Safe. And one of the things they looked at there was what can leaders of a team do to make it more likely that others will share their opinions. And one of the big things they can do is invite input and then thank people for that input. So when I invite input in the conversation, I subtly shape the culture of my duo such that the next time somebody has something to say, they may be more likely to bring it up in the conversation. And this becomes a virtuous cycle, a positive feedback loop where more openness leads to a more open feeling culture, leads to more openness in the conversations. And so what we argued to our sponsors was we think we can use the simulation skill of practicing rapid cycle deliberate practice or other ways of building these conversational skills to help people be able to converse at point of care. Because without being able to flip this cycle into a virtuous cycle, and let me just say before I go back to my us and them photo, what was happening is it was a vicious cycle where I shut you down, and then the next time you're interacting with me, you expect to be shut down, so you come in with a more closed mindset. So you saw that in the initial video where our nurse colleague said, "Oh, here we go again." And so the problem with the vicious cycle version is we can each start coming into conversations with a very us and them point of view where we're the angels, we have a good reason for what we're doing, and the other person is the devil who doesn't. In our hospitals and yours, this is exacerbated by the fact that the puff is out of many people's pillow because of staffing shortages, those downward cost pressures I mentioned earlier. And this is just one of many studies, but this is a really important one for motivating the intervention we designed, which is that one of the biggest drivers of burnout and kind of calling in sick and turnover is contagious negative team dynamics and also lack of recognition. So we wanted to create a way for people quickly at point of care to disrupt those dynamics, but also give each other some love and positive recognition. So how do we flip that conflict cycle to a collaboration cycle? I'm going to get into this in a moment, but I just want to pause for a second here and see how this is landing on you all. What's going through your minds? What about this resonates? What is your experience with these kinds of dilemmas? And do feel free to come off mute and just chat, or if you prefer to text into the chat function, that's fine too.
Lisa's hand is up, Jenny.
Yeah, I just wanted to add, for me personally, what I have found difficult in many of the situations like you've described here is always this sort of sense of hierarchy, not the inability to work with various levels of hierarchy, but the respect required for all hierarchies, be you know, the door greeter to the president, that the respect that the president may have more knowledge, more insight, and more education than you should be respected by all, but also that the person who is at the door also has an opportunity to add to the conversation. That sometimes when those conversations are not dynamically respected, it causes conflict.
Mm-hmm. Thank you so much, Lisa. I think that whether we think about it as respect or positive regard for the other person, regardless of their status, I think that is a key to unlocking some of these dynamics. And I will say that one of the things that we struggled with initially as we were contracting to do this work is we were asked to basically just do a skills training. And we kind of felt the same way you did, I think, Lisa, which is if people don't actually care about the other person or aren't curious about what's going on with them, we can train them till the cows come home, but it's not going to change anything. So a big part of what we ended up having to do was create the type of video that you saw here and give them a chance to really think about what each other were up against and get to a place where we were able to kind of upend the belief that the other specialty was just being mulish and stubborn, and understand that the other specialty had a goal also. Sev.
Hi, thank you. I just, the other thought I have is I think it's important to demonstrate to people somehow that if they do change their mind frames or models, they actually may result in tangible benefits for them.
Yes.
So whether it's going to be a quicker response from nurses or a smile, but if you demonstrate in a similar way, maybe a video or whatever, or through the interactions, the interactive simulation with the standardized patients or whatever, that they will actually have tangible benefits to their day-to-day routine. That's going to be a huge buy-in to and reinforcing kind of agent.
And actually, Sev, thank you for saying that, because it reminds me to say this. In part because we weren't able to get the kind of data collaboration we wanted to get. So for instance, we wanted to do this intervention over time, and we wanted to be able to track such things as people calling in sick and some other metrics that they were already collecting, but we couldn't get collaboration on that. The reason why we were as successful as we were and able to have unit leadership really support this program and ask for more of it is exactly what Sev is saying. So, for example, there was on the neurosurge unit, it was not uncommon for the physician team to order a scan of the patient, the nurses to arrange the scan, which included transport, et cetera, and then for the physician team to kind of suddenly out of the blue in the morning say, hey, we don't want that scan at 10 a.m., we want it at 8 a.m., which causes a huge workaround for the nurses, problem for the MRI suite or wherever they were going. And once we were able to improve the collaboration across this interface, those kinds of irritants that caused rework and conflict for both sides was able to be diminished. And I think that's the kind of thing that allows people to see it's not just learning to hold hands nicely and sing Kumbaya. It actually helps them with what they need to get done every day.
Jenny, in the chat, Amal shared, problems like that tend to be ignored, unfortunately. I love how you approached it as creating a culture of mutual respect rather than solving a kind of unsolvable problem.
Yeah, thanks, Amal. I just definitely knew that we could not tackle those structural problems. And the other, I don't know whether I should call it diplomatic move or jujitsu, organizational behavior jujitsu, was each side was like, they need training. The nurses were like, the residents need training, and the residents were feeling like the nurses needed training. And I said, what we need to do is create this moment where we can mutually support each other at point of care so that we can sort of get on the same page. So I'd like to go back to my question that I left us off at before we started chatting. And that is this: how do we flip from a conflict cycle to a collaboration cycle? And I'm going to build on, to some degree, Lisa's comment about respect and so on by presenting a model that actually comes from mother-baby interactions. And I know that none of us are babies, though I certainly act like one from time to time, I believe. And however, I think this model of attunement and mutual support, or at least support by the mom, is something that we can learn from in this context. So I'm going to play the video, and then I'm going to ask you to think a little bit about, even though this is really different from our everyday work, what are the things this mom is doing that might have some relevance to how we talk to each other at work?
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. here. And what are you doing? Oh, yes. Oh,
So I'm curious about what resonated for you there and how you might relate it to conversations at work.
Nonverbal communication is very powerful.
Yeah, that mutual attunement and in terms of setting up that positive feedback loop, like when the baby points and the mom looks, that idea that I can make a difference in the world, like, wow, look, people look where I point. Yeah, and Tim, you're talking about social isolation as a problem in the animal world, and yeah, and Lisa's saying that, the mom knew to turn it back on. Well, one of the things I think about when I watch this video is we all get really used to the still face experiment, basically. Uh, People don't give us the love, uh, aren't able to just listen to us and resonate. Oh yeah, Sarah's ahead of me here in the chat. And what we noticed when we watched the dyads or duets or duos working before we started our intervention is this kind of mutual non-listening. And so when we did our intervention with the groups, one of the things we did is we would play a video like the one you saw, except absolutely tailored to the unit. So we had one for the labor and delivery unit, we had ones for each unit. And after we played it, what we would do is we put people into small groups. So this is where we were sort of using the simulation method of debriefing, even though there had been no sim. We put people into small groups and we asked them to map out what they thought were the results of that conversation for both providers and for the patient. We gave them a sort of chart to work on. What were the actions that each person took that led to those results? And we thought of talking as an action. And then the part that kind of blew their minds and was the piece that I think was transformational was we then asked them to think about what were the feelings or thoughts. We used the word frames. What were the frames that people were holding that led them to take the action that they took that led to the usually not good result? And these were, clinicians who work together every day, sometimes for years, and we put them in interprofessional small groups to do this. And when they enumerated what were the frames, for example, of Alyssa, the nurse that you just saw, or Dr. Laura, Nurse Alyssa versus Dr. Laura, they were so shocked to that the colleague who they initially thought of as being obstructionist and difficult actually had a good reason and a caring reason for doing what he or she was doing. This was really the fulcrum that transformed behavior. We then also taught them a way to quickly, within about 90 seconds, say what their concern was, ask what the other person's concern was, hear those concerns, and collaborate to transform the plan of care if they could. But it was really the changing of the mental model that the other person was trying to give them a hard time to the mental model that, hey, they have legitimate concerns and I need to know them because we might be able to come up with a better plan of care together. So,
Jenny,
yes,
Tim had
Petal,
made a
please.
comment higher up in the chat where he talked about the concept of work created and being inconvenienced for others does contribute to some of the feelings of disrespect and flippancy that could result from that.
Yes. Okay. Thank you for slowing me down there, Petal. Hang on a second. I'm going to digest that. Right. So, Tim, I'll just take an example from one of our units. I'm sure you experience this daily or often. One of the things that might happen is a more junior resident would come to a nurse and say, I know the plan was A, but now it's going to be B. The nurse would be like, hey, listen, we all agreed it was going to be B. It was going to have how we manage this patient. We're all set up for that. Why? And the resident, the junior resident who had been told by the fellow, who had been told by the attending, had no clue really, but felt very scared to go back up the chain of command to make any waves. And so fear is a very strong driver of rigidity and mulishness. And so would often just be like, because. And so in that unit, one of the things that we worked on, and our video actually represented this telephone game of the attending tells the fellow, tells the resident, and the resident goes to tell the nurse, and how toxic that was for exactly what you're saying, Tim, because they would land these things on the nursing staff, which involved significant rework for them and would not be able to give a rationale. And so that was somewhat transformed when we were able to make it such that either the resident knew the reason from the beginning or was able to go back up that chain of command. But I'd love to hear anything else you have to say about that.
That
Tim,
makes a lot
yeah,
of
go ahead.
sorry, that makes a lot of sense, Jenny, and it I can absolutely see how in systems that are stressed for labor and effort, people are physically and emotionally exhausted at baseline, that anything that generates work that's seen as, or effort or complications that's seen as potentially futile or potentially liable to be reversed, it would just be, people don't have the capacity for that at all.
No, it's like bone on bone. It just really wears people down, I think, when those things happen. And just to address Tim's other question in the chat, which is how did we get folks to adopt this script in an authentic way? I want to just say two things. We gave them a chance to practice, and one of the things that was unfortunate, and I'm sure you've all experienced this, is, our dose was rather small and we weren't able to roll it out across the whole unit in every unit. But the people who had been at the training, and we often had, 20 plus people, kind of started being able to talk with each other and then others in this way. And even though people recognized it as, oh, that's the thing you learned in the workshop, it did kind of have a positive effect because people were able to actually inquire and listen to each other. Yes. And Jasmine, you're just asking, so some of you are familiar with my evangelical work around something called advocacy inquiry. And that is basically what we taught people, which is to preview the topic. Hey, I want to talk about the timing of the scan. I noticed you asked me to reschedule it. So what is the data? Hey, that's going to make a lot of challenges for me because we already have the transport team ready and we have this ready, and we're going to have to reschedule some other patients. Can you help me understand why? So it's a preview. I think, I wonder, listen is essentially what we taught them. Jasmine, just to answer your question, and I'm always happy to talk more about that. So on the theme, yes, right. Sev's point about direct attending. So on the theme of applying simulation skills and mindsets into our real world, what we also did was we did introduce a couple very basic negotiation concepts. So the one that you saw earlier of positions versus frames or positions versus interests. That was one of the mind-blowing things for people, that when somebody says something, that's not all that's going on with them, that there's things below the surface. And then we also introduced this idea that goes under the fancy term in negotiation literature of integrative bargaining. And all that means is, how do we create an agreement where there's a bit of an expanding pie versus win-lose or a set pie? And the example that we use here that I'll share with you is, if you imagine two chefs at the end of the evening at a fancy restaurant. I'll pick one of my favorites here, or I just was at in Oakland, California, Balati. And imagine that the entree chef walks in to the walk-in refrigerator and the pastry chef walks in at the same time, and they both land their hands on the very last orange in the walk-in fridge. And they both need the orange. The pastry chef needs it for her classic orange meringue tart, and the other chef needs it for his signature duck l'orange. And they kind of look at each other and shrug, and they look sort of sad, and they cut the orange in half, and each person, it's a nice compromise, each person walks away with half an orange. Except if they'd just taken a moment to find out what each other really needed, it turns out the pastry chef only needed the skin or the zest for her meringue tart, and the entree chef just needed the juice for his duck l'orange. They could have had entirely exactly what they both wanted. And so I think we often assume, we have to compromise. I'm going to give half of your medication and I'll give half of, no. But that we can actually come to a really more meaningful solution if we listen to each other. So one of the things that I think is really crucial is resetting ourselves. And Petal, I'm watching the time here. I'm going to share this and share a final video, and then we'll have a few minutes to chat. When I'm thinking, what the F are you doing? Like, you are such an idiot. Having some sort of a reset routine for myself that lets me get curious about your frame. And so this idea of switching from WTF, whenever I think WTF, if I can force myself to think, hey, what's their frame? That can be a really powerful way to change these dynamics. And that's where we did see success on the units. That's what was happening. And so I want to just play what this looks like when it's going well. And here's that same video, except after, imagine before and after. This is staged, but this is the kind of thing we taught people to do.
Oh, hey, Alyssa. I'd like to start getting set up for the HD line so we can start CRT, okay?
Here we go again.
Hey, can I check in with you about this plan? I'd like us to get on the same page. I can see that you're not super psyched about starting HD. So here's my thinking. He has bad CHF and sepsis, and I think with antibiotics and CRT we can get some fluid off and see if we can get him through this. What are your concerns?
I mean, I agree. He is really sick. I hate to give false hope. I don't want to see anyone go through that.
Yeah, I hear you. Thanks for speaking up. And I know it's hard to be the one in the room doing the work. We promised we'd try to get him to his daughter's graduation, and I think it's reasonable to try. So,
well, thanks for acknowledging that it is difficult. I do think it's reasonable to try.
All right. We'll try for a few days, and if we don't see any progress, we might revisit the goals of care.
All right, guys, just to let you know, that was 80 seconds. So I just wanted to highlight, we were really, really focused on having these conversations be quick, because we know people don't have all day. So I'm going to just...
Oh, hey, Alyssa. I'd like to...
So I'm just going to end with this thought and love to hear yours. So I think that this kind of culture change starts with micro conversations. So conversations do gradually build culture, for better or worse, vicious or virtuous. I think they start with curiosity and or positive regard for the other person. And so resetting yourself is the one thing you can control, and getting curious about the other person can be the start of a culture reset. So I think we have a couple minutes. Love to hear any thoughts or questions.
Thank you, Jenny. That was so beautifully done and very interactive. And I think everyone has access to the email we sent. And if you haven't, please email Ricardo and myself for Jenny's podcast, where you can then go into more depth into this work and all the other advocacy inquiry, the other groundbreaking work she's mentioned. But I agree with you that for me, the take home, the WTF to WTF is going to stick with me all day. Any comments? We have 1 minute left. Any questions, comments?
Just wanted to quickly say this study, I just think it's fantastic. I learned a lot. Thank you so much, Jenny. How different could it be if we just texted each other?
Good or bad?
I don't know. How would conversation and directives be taken without the actual physical person, voice, imaging, like the mother with the baby? What if it was just a text directive? Do we take it differently?
Right. Great question. Yes. I mean, Laura Rock, who was on this project with me, often was working with the residents on the units that we were in to say, hey, listen, that's not a text. You need to just walk over and talk to the nurse.
And tone and affect are so important, especially in difficult conversations. So I think that this has been really helpful. Curiosity and respect. Somebody in the chat mentioned civility is not the same as understanding a person's position, but then Lisa responded, it's a good place to start. And so you definitely set us all on the right tone towards culture shift with micro conversations. Thank you again, Jenny. We're so grateful for you, and we look forward to having you back again in the future.
Thanks, Petal. Thank you all for
Thank you, Jenny.
taking your precious lunchtime to spend some time here.
Bye, everyone. Take care.
Bye.